Neuro. I've put in my details there. If anyone wants to contact me with any questions, feel free to. So in terms of what we'll cover, I've kind of bolded the R1 conditions from the matrix, and I'm really going to aim to deliver everything in this format. So starting off with just some basics, so some first principles that will really ground you in the topic itself, then the content, so important things to know for exams and OSCEs, and then ending up with some pearls, so just things that I've learned on the wards, or some extra things that really helped me understand the topic well. I might not get to cover everything in today's session, so that's why I put in my details, so feel free to ask any questions that you might have. So we'll start off with iron deficiency anemia. So it's a really big topic, but I found that going from third year to fourth year, I really knew the basics, but there were a couple of things that I didn't really have a good grasp of. So the basic things to remember is that ingested iron is an indicator of the serum iron, and that remembering that ferritin itself is an acute phase reactant, so it does go up in inflammatory conditions. And there are different cutoff values for anemia in different age groups. I don't think you necessarily need to remember the cutoff values because they often give them to you in the exam, but it's just something to keep in mind. So the way that I like to think about iron deficiency anemia is it's either one of three problems really. So either there's a problem with making the red cells, or something's destroying the red cells, or you're losing the red cells themselves. And then in terms of that, we can then break it down further into going into further kind of conditions that cause each of those categories. And I put them in there for your reference. So in terms of the content itself, what to know for exams, it's a really common condition. So I would definitely recommend knowing iron deficiency anemia well. You can also break up the risk factors depending on the age of the patient. So are they an infant or are they a child? With children, they often present with similar risk factors to adults, but with infants, they're a bit different. So it's more likely due to nutrition. So things like an intrauterine growth restriction, or just having too much cow's milk, so greater than 700 mils, or breastfeeding following a period of 6 months. So these are really some risk factors that predisposes an infant to iron deficiency anemia. In terms of our clinical features, you really think about it as, if there's a reduction in the ability of the red blood cells to carry oxygen, what would that result in? So things like tiredness, pallor, in children especially, it could be a change in behavior, irritability, or lethargy. And then difficulty concentrating as well in school. So I know with Monash, they love to put in the difficulty concentrating question in the STEM, which usually results in either like an iron deficiency anemia picture or like a hypothyroidism picture. Shortness of breath is a little bit more as we go along the severity of the iron deficiency anemia process, and then resulting ultimately in things like pica, so eating things like chalk and dirt. So in terms of your differentials, there's two really main ones that I think about. First of all, could it be an anemia of chronic disease? Or could it be something like a beta thal trait, which we'll go through later? And often in Monash, the kind of indicator for that beta thal trait is the ethnicity of the child. So in terms of investigations for this, it's pretty similar. It's an FBE plus or minus a peripheral smear, and you can consider iron studies, but I'll talk about that a little bit later. And then we have a management that's quite important for you all to understand. So I put this on the next slide. I generally try to keep all the content onto one slide, but if it's not possible, then over two. So breaking it up into kind of lifestyle, pharma, and then more invasive methods of iron delivery. In lifestyle, really what we want to start by doing is increasing iron-rich food. So that's a really good place to start, but also decreasing cow's milk. So first of all, it's really important to ascertain whether a child under 1 is being given cow's milk, because really they shouldn't. But if they're over 1, then we really want to limit it to 500 to 700 mils a day. And we want to refer this child and their parents to a dietitian. In terms of pharma, though, we have two kind of ways to target iron deficiency anemia, either preventative or treatment doses. And these change in milligrams depending on which one we're trying to target. Another thing to remember as well is, so when we give iron supplementation to a child, we want to wait 3 months, so continue the therapy for 3 months, and then we look at the serum ferritin. And then in terms of invasive, that's obviously IV iron. It's rarely used, but we do use it in these kind of 4 conditions. So the main one is following a period of 3 months, when we do the serum ferritin, there's no response to the oral iron. If there's severe GI disease, so things like Crohn's, if there's any blood loss, so the body cannot replace the red blood cells at such a rate that it's losing it, and then rapid repletion if required for things like surgery. So in terms of some pearls that I thought were really important when I was going through, the first thing is if this is a consent station or if you're speaking to a parent of a child who is going to get iron supplements, the first thing is that iron can turn the stools black and it can also stain child's teeth. So the main thing, I guess, of advice that you can give to these families is consider brushing the teeth straight afterwards with something like baking soda, and also drinking the per-oral solution with a straw to avoid that staining. It's also better alongside vitamin C. So something that you could recommend is taking alongside a glass of orange juice first thing in the morning. And as well, just reinforcing to parents that over-the-counter vitamins do not have enough iron for repletion of iron stores in a patient with iron deficiency anemia. So now moving on to ITP. So really it's an autoimmune condition and it usually presents asymptomatically after something like an upper respiratory tract infections. You really don't want to give these children anything that can precipitate risk of bleeding, like NSAIDs and aspirin, because of course it's a condition that reduces the amount of platelets in the blood. It's a diagnosis of exclusion, so there's really nothing that can rule it in. But the main things that you want to make sure is on exam, you shouldn't have things like pallor, hepatosplenomegaly, or lymphadenopathy, and we'll come to that later when we talk about our cancers, so leukemia. And really the main thing here is the decision for treatment is always made by a pediatric consultant. So in terms of ITP, it is quite rare, and it's usually seen in children following a viral infection, like I said before. But there is also a chronic form of ITP that can be seen in females of reproductive age. So the main clinical feature is purpura, because it's a platelet, you're reducing the amount of platelets in the blood. So that's why you're getting purpura. In severe cases, you can have things like mucosal bleeding, epistaxis, or melena, and even hematuria. So on investigations, you're going to do an FBE and a smear. The FBE will show low platelets, and the smear is really there to rule out leukemia. And you'll also do an abdominal ultrasound if you can't say definitively on exam that there's no splenomegaly. In terms of the management here, it really depends if they can be outpatient or inpatient. So the easiest way to think about this is that if there's any bleeding, so a nosebleed, bleed in the urine, anything like that, then the patient needs to be admitted. The patient can be treated via outpatient if the platelets are over 20,000 and there's no risk of bleeding. So these patients need no steroids, no treatment, you're just monitoring them here. In terms of any extra things to kind of tell the family if this ever does come up, they really want to avoid things like contact sport. I shouldn't say support, sorry, contact sport. They should live to the ED if you need them to come back in, and they should avoid things like intramuscular injections. And there is a rare case of intracranial bleeding, but it's really rare, 0.5% of patients. So of the 1 in 100,000 patients that get ITP, a further 0.5 will develop intracranial bleeding. So in terms of the pearls, the main one here is just making sure that it's a non-blanching rash. So the best way to do this is to use something like a glass or even like a urine specimen container if you can't find a glass to push down over the rash just to make sure that it doesn't blanch. And a good way to form the differential for ITP is to think about normal platelet versus low platelet. So if we think about low platelet, we're thinking about things like ITP, but also things like leukemia, and also possibly things like DIC, which again is rare, but you don't want to miss. And then if there's normal platelets, you're thinking about things like sepsis. Could this be a trauma picture, or could this be HSP, which we'll cover a little bit later. So now we're going to touch on leukemia, specifically ALL, because this is the one that predominantly affects children. So the basics of this are that 80% of all cases of leukemia in children are ALL, and really this is an uncontrolled proliferation of immature white blood cells, and this results in blasts seen on the peripheral smear. So really, the bone marrow is trying to pump out these white blood cells that aren't really doing much, that clog up the blood, that clog up the bone marrow, that clog up the liver, that clog up the spleen. And this is why we see, a lot of the symptoms and signs that we'll talk about on the next slide. So it's seen mostly in children 2 to 5 years. And in terms of the classification, we've got, Yeah. So in terms of the classification, ignore that. That's from the ITP slide. So mainly it's acute and it affects children within that 2 to 5 year age gap again. And then when we think about other forms of leukemia, it generally comes on later in life. In terms of the clinical features, we have, first of all, our B symptoms, so things like weight loss, night sweats, fatigue. And then we have our symptoms of bone marrow infiltration. And the most common one of this would be bone pain, so long bone pain. And then we can have our hepatosplenomegaly, and then our lymphadenopathy. And this is why we want to differentiate something like leukemia from something like an ITP. In terms of the investigation, so there are a number of investigations, but the first thing that you'll be doing is an FBE and a smear. The FBE will generally show low white blood cells, and the smear will generally show blasts. Other things that you can do later on are things like clotting screens, bone marrow aspirates, lumbar punctures, and chest x-rays. But the first thing that you'll want to do in these children is an FBE and a smear. So in terms of management, again, it's a little bit complicated. You probably wouldn't need to know this for exam-specific questions, but I've just put it in there just in case. So the first thing that you'd want to do is to correct any anemia that might result. And that's because you really want to ensure that there's proper oxygen delivery to the tissues and that children are largely asymptomatic. Another thing that you want to do is to treat any infection. And I've got a slide a little bit later on talking about hematological and oncological emergencies, and we can go through that. You want to make sure that the patient's well hydrated as well, because in a lot of cases, these patients can be volume depleted. Then there are certain things that you can do to help with some of the side effects that leukemia presents with. So first of all, something like allopurinol. So allopurinol really prevents against the side effects of a condition called tumor lysis syndrome, which we'll go through, and it's really there to lower urate and to protect the kidneys. Chemo and steroids really together. So the chemo obviously is to attack the blast, but the steroids is to reduce any swelling that may result and any inflammation that may result. And then specifically for APML, which is a subtype of leukemia, we can treat that with all-trans-retinoic acid. So some extra things to know. Generally, most people remit with leukemia, 95%, and that they may need things like bone marrow or stem cell transplants, but this is probably above our scope of practice. Really here, so if you ever see an FBE and there's a pancytopenia and on peripheral smear there are no blasts, then the first thing that you should be thinking about for that question is aplastic anemia. So in terms of APML, it's one of the subtypes of leukemia that is most likely to cause DIC, and 10% of patients with APML will present with DIC. The reason for this is because you've got this increased phosphate, which then leads to a decreased calcium and magnesium level in the blood because phosphate binds those two. This then leads to increase of procoagulant factors, which use up clotting factors, and then you get that DIC-like picture. Another one to remember as well, and this has come up before on Monash questions, is that myelomonocytic AML is the one that causes the swelling of gums. So this is just something to remember as kind of like a buzzword if you ever do see that question come up. Okay, going through thalassemia. So first of all, with alpha, it's an autosomal recessive condition. And really the most important thing here is that there are 2 copies of A1 and A2, which are responsible for making the alpha chain on hemoglobin. So altogether then there are 4 copies, right? So you've got 2A1, 2A2, so there's 4 of them. So if you lose 1, you're a carrier. If you lose 2, then you've got alpha minor. If you lose 3, you have something called HBH disease. And if you lose 4, then you get something called HB Barts. So HB Barts is usually has a very high mortality. Children die in utero. And it results in hydrops fatalis. So there's just not enough red blood cells to carry oxygen around the body, results in this fluid overload-like state that's not really compatible with life, ends up with heart failure, and you get that classic looking picture. In terms of beta globin, that's on chromosome 11, and that's what really results in beta thal. So you either have a reduction or a loss in beta globin. And this is the one that's more common in Asian, Arabic, and Mediterranean children. So this is really looking again at the types of hemoglobin, just remembering that, fetally, you've got your gamma and alpha chains, and then in the adult, you're moving to beta and alpha chats. So in terms of the symptoms now for alpha and beta, the symptoms for alpha are very similar to iron deficiency anemia, except there's a hepatosplenomegaly. So again, differentiating that from something like a leukemia-like picture would be on peripheral smear. And then symptoms of beta cell are really jaundice because there's a hemolysis. With the hemolysis comes excess iron, so you get a hemochromatosis-like picture. And on X-ray, you get this hair on end appearance. So I put that X-ray in there. Looking at the skull there, you can see those tiny hair-like projections over the skull. And the children also get things like an enlarged forehead and cheekbones, and that's called chipmunk faces. So in terms of diagnosing and managing both of these conditions, so it's a microcytic hyperchromic anemia, similar to iron deficiency anemia. However, on blood smear, you'll get target cells. So you won't get blasts like leukemia. The main way to diagnose these two are hemoglobin electrophoresis to separate the bands and to look for any difference in the hemoglobin. And you can also do prenatal genetic testing. So in terms of the management, if there's mild, there's no treatment. If it's severe, then you'll need blood transfusions and iron chelating agents, because if there is a hemolysis-like picture, you want to get any excess iron out of the blood. And then if there is a complete loss of the alpha thal gene, then you will need in utero transfusions for those children to avoid that hydrops fatalis picture. Again, looking at beta thal, it's very similar. With beta thal, often you can also get high red cell distribution width on the FPE, and that's because you've got lots of red blood cells of different sizes. In terms of the peripheral smear and iron studies, it's very similar. And again, we diagnose it on hemoglobin electrophoresis. The management here, so minor, again, there's no treatment, but with major, generally you need monthly blood transfusions and iron chelating agents. So in terms of the pearls for beta thal, so you've got these alpha chains accumulating and they destroy the red cell membrane, and that's why you see hemolysis through the spleen. With hemolysis comes excess iron, which then leads to hemochromatosis. So these children can present with hemochromatosis-like symptoms. The hemolysis then leads to hypoxia, and that's when we get the anemia symptoms. Then the bone marrow, the liver, and the spleen try to increase the red blood cells, and that's why we get the anemia and the hepatosplenomegaly. So now looking at hemophilia. So really this is a coagulative disorder, and it's X-linked recessive. So women are generally carriers. Hemophilia A is more common and results in factor VIII deficiency. Hemophilia B, also called Christmas disease, far more rare and results in factor IX deficiency. Remembering that factor VIII and factor IX are in the intrinsic pathway, so we get elevated PTT. The way that I like to think about this is PT and PTT. So PT, play tennis, you play tennis outside, so it's extrinsic, and PTT, you play table tennis inside, so it's intrinsic. So that's why we get an elevation in PTT. And the clinical features of both of them are pretty much identical. So really supporting this would really be looking at genetic studies and clotting studies as well. So the clinical feature for this is bleeding. So things like nosebleeds, bleeding into the joints, bleeding of the gums when brushing teeth. And it really presents in the first year of life. So generally after about 3 to 6 months, this is because babies commonly fall and start bumping into things around that time. So again, on diagnosis, you'll get an elevated PTT because it's an intrinsic factor disorder. Your platelets and your PT will be completely normal, and you can do specific factor activity testing on clotting studies or genetic testing. So the treatment is really simple for this. For type A, you give them 8, which is what they're missing. Type B, you give them 9, which is what is missing. So 4 main things to kind of consolidate the knowledge of hemophilia here. So the main differential for hemophilia type A is von Willebrand's disease. That's because von Willebrand's disease is a stabilizing factor for 8. So if you do have a reduction in von Willebrand's factor, then factor 8 won't work as well. So that's why it's a main differential. In these children, similar to ITP, you want to avoid aspirin, NSAIDs, and any intramuscular injections because it's an increased risk of bleeding. Another thing to remember as well is that patients can develop inhibitors against the recombinant factors. And that's because, so in the diseased person, whether they have factor VIII or factor IX deficiency, there's little exposure in the blood to these factors. So the body can actually develop antibodies against these factors. And then when you give the patient an infusion, it can lead to things like anaphylaxis in the very severe case, but it can also lead to degradation of the factors by antibody and then complement destruction. Also to know in type A for minor things like minor procedures that can cause bleeding, so things like stitching and things like minor dental work, you can give them desmopressin. And that's because desmopressin stimulates the release of von Willebrand's factor from the endothelium. And just remembering that von Willebrand's factor stabilizes factor 8. And so this is a really good way to just make sure that there's a lower risk of bleeding in these patients. So moving on to HSP now. So this is an IgA-mediated immune condition, and it is the most common vasculitis in kids. So commonly occurs, 1 to 3 weeks after an upper respiratory tract infection, and the general age of presentation is 2 to 8 weeks. And you get this classic rash that presents on the trunk and the buttocks. So the main symptoms are things like joint pain, hematuria, abdominal pain. And then there'll also be palpable purpura. And the palpable purpura is there because of IgA deposition in the skin. In terms of diagnosis, if you do a urine analysis, you'll see gross hematuria, or you might see microscopic hematuria. And then you'll also see red blood cell casts. You can also do a skin biopsy, which will show IgA deposition, but this is not done in all cases. So in terms of treatment, the main thing is elevation of the affected limb. And this really helps for pain and edema. So this is something to note for OSCEs, but also steroids. But steroids have really been shown as limited use in this condition. It's self-limiting and generally resolved. So the main thing that you want to address in these patients is elevation of the affected limb, just to help with pain. So Rhesus ABO incompatibility is something that we think about quite commonly in the child that presents with jaundice, and this is an R1 condition. So the basic things that I really want you guys to know is that Rhesus disease is worse than ABO, but both have antibodies that can cross the placenta. In ABO disease, it's a problem with red blood cell incompatibility. So you have IgM antibodies which attack the surface of red blood cells, which then results in red blood cell lysis. Another thing to remember as well is the body always produces antibody against antigens that you don't have. So if you have type B red blood cells and you have type B antigens on the red blood cell, then your body will produce antibodies to A. So it's always against things that you don't have. Rhesus, again, same as above, more severe. And just remembering that, mums often require sensitization. Not often, they do require sensitization. So generally on the first time a mother is exposed, if she's Rhesus negative to something Rhesus positive, it's not really a problem, but in subsequent cases it is. So in terms of investigation, we have group and hold and cross-match. So cross-matching is really when we're identifying the antibodies that are present in the person's plasma. A group and hold is specifically telling the laboratory that you want these cross-matched blood that you need for the patient held separately in case you need it. So group and hold and cross-match don't necessarily always go together. You can do a cross-match, say, for example, in an antenatal appointment, but then do a cross-match and a group and hold before a cesarean section. And then we'll also want to do direct Coombs for ABO incompatibility. So in terms of treatment for babies that do have either of these conditions, the first thing is if there is jaundice and if it crosses that nomogram cutoff value, we can do phototherapy. And this is really to avoid things like kernicterus if the bilirubin level is too high. I'm just reminding you that kernicterus is when you have hemoglobin depositing in the brainstem. Then if it's something like hydrops fatalis, like if it's a severe hemolytic reaction that's really depleting the red blood cells, the children will require blood transfusions in utero. And just a reminder again that hydrops fatalis also presents if you have 4 deletions in alpha thal. So this is really the red blood cells are pretty much useless and there's a severe heart failure like picture. And then just remembering as well that anti-D is given to really combat this, and it's given at 34 weeks, and then a large dose is given following delivery. So the main complications of Rhesus and ABO are hemolysis, kernicterus if it's really severe, hydrops fatalis if it's really severe. And if this is going on for a long period of time, you can imagine if red blood cells aren't carrying oxygen around the body, there can be severe growth restrictions as well. So some pearls for ABO and Rhesus. AB is the universal recipient because there's no antibodies, and O is the universal donor because there's no antigens. A Rhesus positive person can receive both Rhesus positive and Rhesus negative blood. And just remembering as well, because this is something that I always got confused about, the difference between a direct Coombs and an indirect Coombs. So the direct Coombs tests for antigens on red blood cells of the patient, whereas the indirect Coombs looks for antibodies in the blood plasma of the patient. So that's really what they're testing there. So going into some onc emergencies. So first of all, the framework for any emergency, if it does come up, is first of all doing your doctor's ABC. And then once that's done, calling a met call. So really calling for help early. You'll be putting in 2 large bore cannulas, so 18G, and that's the green cannula, and any relevant initial management and any relevant initial investigations, which we'll cover. So for heme, the 2 that I want to go through are febrile neutropenia and tumor lysis syndrome. So febrile neutropenia is when you have really high low neutrophils, so neutrophils under 1 and a temperature above 39. The main thing that you want to do in terms of investigations is a blood culture. So you'll get a blood culture from 3 separate sites, plus any lumen. So things like a central line or anything like that, you'll get a blood culture. And the treatment for this is IV tazocin 4.5 grams 4 times a day. In terms of tumor lysis syndrome, this is really an effect of cells that are lysing. So 2 things happen here. You get high potassium, phosphate, urate, and LDH, and you get low calcium. So in these patients, you want to give them IV fluid. You want to give them resonium, and that's for the high K, and then something called rasburicase, which really targets the high urate. So the high urate, lowering the high urate protects the kidneys, but also protects against flare-ups like gout. And the resonium is there really to protect against the high K and to ensure that you don't get a hyperkalemia-like picture. And in these patients, you might even need to give calcium gluconate to stabilize the cardiomyocytes. And then we have hyperviscosity syndrome and DIC. So hyperviscosity syndrome can present in ALL, and this is a blast crisis. So this is when the white blood cells are really high, above 100. They can get things like headache and blurry vision because you're getting that really thick blood that's clogging up in the arteries. And the main treatment for this is IV fluids and plasmapheresis. The main thing is, though, to really treat this, you want to expedite treatment in these cases because the headache is usually a kind of like a preceding symptom to stroke, and the blurry vision can be a preceding syndrome to retinal artery occlusion, which can lead to blindness. Then we have DIC. So this is, our cytokine storm, and these inflammatory factors end up consuming clotting factors. So the patients clot first, and then they bleed. So you have really low platelets and fibrinogen, and you have a really high iron APTT because these patients are bleeding. Can be triggered by things like sepsis and surgery in patients with ALL. And the main thing to know here for exams is cryoprecipitate, and fibrinogen is the treatment. Apologize again for moving so fast, but again, my details are at the front, so if anyone has any questions, please do ask. So we'll move on now to neurology. I even finish ahead of time. So in terms of epilepsy, so the basics for this condition are that it's a seizure-like condition, and you have synchronously active neurons. So you have misfiring of small groups or large groups of neurons that are active. 2 kind of basics for this is that you have glutamate. Glutamate is excitatory. It binds to NMDA channels and it lets calcium into the cell. And so we can have glutamate, we can have too much glutamate, or we can have NDMA channels that are excessively open that leads to firing. Then we have GABA. GABA is inhibitory. It binds to the GABA receptor and lets calcium into the chloride into the cell. And we can also have cases where the GABA channels are not open for long enough. So we can either have too much excitation or not enough inhibition. In terms of the types, so it's broken up into generalized and focal. So you don't really call them grand mal and things like that anymore. And in terms of generalized, the 2 main ones to know for Paeds would probably be your tonic-clonic, which is your classic, and your absence seizures. You have your other ones there that you can remember, but generally for exams, it's your tonic-clonic and your absence. So in terms of absence seizures, it's generally seen in males more than females. There's this brief loss of consciousness, generally under 30 seconds, and they get this blank stare. So often in Monash questions, they say things like, you've got this younger child and they just briefly stare out of the window for a period of time and then just snap back into consciousness. In terms of focal, so generalized, it's all over the brain. With focal, it's in a specific area. It can either be with impaired consciousness or without impaired consciousness. With impaired consciousness can lead to things like incontinence and nausea and vomiting. And so during the time of the seizure, you cannot speak to this individual. You can't get their attention because they're just like completely out of it. Without impaired consciousness, they're often aware of it, and they have problems with sensory or motor areas. So they'll either have something like a tic, like a finger kind of movement or a wrist movement, or they might feel sensations around their body in a specific area. In terms of the main kind of differentials, so breath holding spells for younger children, syncope, GORD. So in very young children, the posturing of Sandifer's syndrome can be very similar to certain attacks in epilepsy, and we'll go through that. And it could even be daydreaming in a really young child. Investigations, there's a big group there, and they're really trying to rule out structural infectious causes of epilepsy, things like meningitis and things like that, or even certain toxins. And then the treatment. So first of all, there should be a buddy system for showers. So someone should be supervising them when they have showers so they don't fall and hit their head. And they should really be avoiding baths, because if they have things like baths on their own and they do have a seizure, there's a chance that they can drown. If they're in a child that's 17, 18 years old that's driving, it is reportable. So there needs to be a 1-year period of no seizures to allow them to drive. Then the three different kind of types of the three different types of seizures, the way we treat them. So for generalized, it's valproate. For focal, it's carbamazepine. And for absence, it's ethosuximide. And these are just things that you commit to memory. In terms of some must-know for exams, there are some extra kind of Peds-specific epilepsy conditions. So the first one is called Ohtahara syndrome, and it generally presents in the first quarter of life. And these are really these recurrent unprovoked seizures, and they damage the brain. And it's generally due to some type of structural or metabolic disorder. And there are a large amount of seizures, so generally more than 100 a day. And you see this thing called a burst suppression pattern on the EEG, and I've got some pictures later for that. Then you have things like West syndrome, which is your infantile spasms, and they get extensions of the limbs. On EEG, you get something called hypsarrhythmia, which is your high amplitude chaotic spikes, and we'll see that soon. And it can result in intellectual disability, because only really 33% of children will grow out of it. And then you have something called Lennox-Gastaut syndrome. It's seizures that eventually will lead to an intellectual disability, because the amount of seizures and the strength of the seizures are really not compatible with neurodevelopment. And you see this triad. So you see this really slow spike on EEG. They have cognitive dysfunction, and they have different seizure types all presenting at once. The thing with West syndrome is it can also be a good differential for West syndrome is also something like intussusception, which I think Ben went through before. So you've got that, extension of the limbs and then that drawing up that can present. So again, looking at West syndrome, there's the hypsarrhythmia, and Ohtahara, you're seeing that burst suppression. So you can see after that quick burst, there's that really the flat line in the EEG, which is classic of Ohtahara. And then with the West, you're kind of getting that hypsarrhythmia, so that kind of multiple chaotic EEG pattern. So some pearls to know that it might be due to a main cause. So doing, looking for things like a tumor, looking for things like infection may get rid of the seizure-like activity completely. Even registrars struggle with EEGs, so just know those two basic patterns. Like I still have no idea what's going on in any EEG, so that's completely fine. Just remembering as well that with a seizure comes reduced oxygen, comes to stress on the brain. And the earlier this presents in a child, this can lead to more detrimental effects on neurodevelopment. The other thing to remember as well is if you've got a patient with vague seizure-like history from the patient, from the parents, and you can see from their charts that there's a delayed picture to their milestones or even a regression in milestones, you need to be really careful and always investigate for epilepsy. And lastly, now we have febrile convulsions. So main thing to know is they occur with a fever. They're common, so generally present from 6 months to 5 years. The fever should generally be above 38, and we have two different types. So we have simple. So simple is tonic-clonic. there's a full recovery in 1 hour and doesn't repeat again in the same febrile illness. And generally the seizure lasts for less than 10 minutes. And then we have complex. So long seizure, it can be a focal type seizure and it will repeat multiple times in the 24 hours. It's clinical diagnosis, so there's no there's no room for EEG in simple febrile seizures. And in terms of treatment, none is really required. The main things to know here is seizure first aid. So call 000 if it lasts longer than 5 minutes, and really ask the patients to keep track of time. The main thing here is two things I guess to tell parents. So first of all, antipyretics like paracetamol don't really show any difference in reducing the risk of having further febrile illness. And having a simple febrile seizure doesn't increase your risk of getting epilepsy. It's still 1%, which is the same as the normal population. And I guess some other things to see. Let me go back. Some other things to say as well is in terms of explaining this if it comes up in an OSCE station, because it is very common and it is likely. The main things that you really want to tell parents are, take the upper layers of clothing off the child, open windows and turn on something like a fan. Make sure that the child's in a safe environment. So placing a pillow around the child on both sides, making sure that they can't bump into anything, and if they can, either record the seizure on their phone or definitely time it, so that then you can relay this if you do need to go and see the doctor. So in terms of why it's caused, there's not really a well-known idea behind why it's caused, but this is something that I weirdly got asked 2 times by separate consultants when I did my Paeds rotation. And so really it's because when you have a raise in body temperature, you get 2 things. So first of all, the raise in body temperature results in neurons more likely to fire, and that's likely because of increased ability of those voltage-gated channels to work. But also, when you get a high temperature, patients often hyperventilate. That then leads to a respiratory alkalosis, which in turn leads to increased firing of neurons. So that's really the main kind of 2 reasons that I thought currently of why a febrile illness can lead to febrile seizures. And they're generally something that we see in younger children as well. And that's also because of, an increased chance of neurons firing in those younger children. So that's all I have for you today. It was very quick, but again, feel free to ask questions. And if I can't answer them now, I'll definitely look them up and get back